Hello, my name is Richard O'Neill from the University of Kentucky, and I'd like to present a study titled Rechallenging with Immune Checkpoint Inhibition After a Treatment-Limiting Immune-Related Adverse Event. We have three main takeaways from this study. Number one, patients who experienced an immune-related adverse event had an improved overall survival compared to those who did not experience toxicity. Number two, patients that were rechallenged with immunotherapy after experiencing toxicity were unlikely to have recurrence of their initial toxicity. And number three, although rechallenging was generally safe, we did not demonstrate an improved overall survival when comparing patients that were rechallenged versus patients that were permanently discontinued. As we all know, immunotherapy has revolutionized the way we treat cancer, though it is not without toxicity. In clinical practice, we often struggle with what to do with patients who experience these side effects. Do we discontinue permanently, or do we give the patients a chance to be rechallenged? We performed a single institution review of every patient that received immunotherapy over the course of about 3 years, focusing on those who either discontinued or had delays in treatment secondary to immune-related adverse events. We identified a total of 562 patients who underwent immunotherapy. Of those, approximately 22% had a treatment-limiting side effect. Of those with toxicity, 2/3 were rechallenged, while the remainder were discontinued. Of the patients that were rechallenged, the majority, or 59%, had no further treatment-limiting toxicity, while the remainder were evenly split between new toxicities at 21% or recurrence of the initial toxicity at 20%. We found that patients who experienced a treatment-limiting toxicity lived longer than those who did not have toxicity, with a median overall survival that was not reached at 36 months compared to 8 months in patients without toxicity. Interestingly, when we substratify the patients who had toxicity into those that were rechallenged versus those that were discontinued, we saw no survival difference between those two populations. In conclusion, patients who stopped immune checkpoint inhibition secondary to toxicity had relatively low rates of recurrent toxicity when they were rechallenged. In fact, they were just as likely to develop a new problem as they were to have recurrence of their initial toxicity. Patients who did develop initial toxicity had an improved overall survival compared to those who did not have toxicity. And rechallenging, though it appeared relatively safe, was not associated with any further improvement in overall survival compared to discontinuation.